So good evening, doctors, everyone who's logged in today. This series is again a part of the CPCDM course, which is a joint collaborative effort between RSSDI and Daily Rounds. Just to give you a single brief introduction, I am Dr. Shalini Jaggi. I'm a diabetologist practicing at Delhi. I have my diabetes center called Life Care Diabetes Center in New Delhi. And I'm an active member of the RSSDI. I've been the national executive body member, as well as I'm currently serving as secretary of the RSSDI Delhi chapter. So without taking much time, let me start sharing my slides. I hope my screen is visible to everyone. So what I am going to do today is talk to you on diabetes management in specific situations. So there are many times patients who come to you with some kind of complication. It may be an elderly patient, it may be somebody who's already got some amount of CKD, or somebody who's got CLD. So I'm going to touch upon these three important specific situations that we see in our day-to-day practice, and how are you supposed to manage these patients. Now, this is something that all of us know, a very high prevalence of diabetes in India, significantly high in urban areas, but the rural areas are fast catching up. And all of us as doctors at times see in our OPDs patients who have diabetes or even pre-diabetes, and patients on the other end of spectrum where they've already developed some of the other complication of diabetes. Now, when it comes to managing hyperglycemia, I think we all know very well, it starts with lifestyle modification. You tell your patient to eat a healthy diet, a balanced diet, low carbs, high proteins, good amount of fibers, and a good mix of all the nutrients. Physical activity is a very integral part of diabetes management. You tell your patient to either walk or do some outdoor sport or any form of aerobic exercise along with muscle strengthening, which not only improves the HbA1c levels, but the overall health of your patient. Now, medications or pharmacotherapy is again a very important part of diabetes management, and we know there's a whole different plethora of medicines that are available today. Earlier, we had only metformin and maybe sulfonylureas to treat our patients, but now with scientific advancements, we have both the insulins, different types of designer insulins available to us, and the oral drugs, which includes biguanides, metformin being the most important, SGLT2 inhibitors, sulfonylureas, glitazones, DPP4 inhibitors, meglitinides, alpha-glucosidase inhibitors, bile acid sequestrants, though we don't use them much in our country, and dopamine 2 agonists, again not used too much in our country, but yes, we do use them for certain patients. Now, why we need to control diabetes for our patients is very, very important. It is not only getting the fasting sugar or the postprandials or the HbA1c down, but the overall glucose management indicators have to improve, because UKPDS very clearly showed that even a 1% reduction in HbA1c for your patient translates into a huge reduction in both micro as well as macrovascular complications of diabetes, reduces deaths from diabetes, reduces the risk of fatal, non-fatal MIs, reduces heart failure, and of course improves the quality of life. Now, complications of diabetes, I think all of us know, microvascular and macrovascular. So I am going to touch upon the microvascular, amongst which I'll talk about patients with nephropathy, how you manage them, and then I'll touch a little on the CLD aspect of diabetes management, a very important comorbidity. Now let's look at the CKD spectrum that usually we see our patients landing up with. Let me start with Mrs. Amelia. She is a 58-year-old school teacher who's been diabetic since 2020. She's also got hypertension and dyslipidemia as part of her comorbidities burden of diabetes. Now, if you look at her clinical reports, she's come to you with an HbA1c of 7.8. The LDL cholesterol for this lady is 140. Her BMI 28.3. So we know there are weight issues involved here. When you look at her pharmacological therapy, she is already on metformin, sitagliptin, along with a statin and irbesartan. Now, for this patient, if she comes to you in the regular OPD, of course, she's not coming and telling you that I have any kidney issue. So if you look at this patient, Is she at risk for CKD is what you need to ask yourself. Of course, there are no signs or symptoms of CKD that she's presented to you with. She's just come for glycemic control to you. But this is a very important thing that you need to keep in mind when it comes to any patient with diabetes who walks into your OPD. Is this patient at a risk of CKD? Does she have some amount of CKD already? Or is she at a risk and you can do something about it? Why I am saying this is because we know that CKD is highly prevalent. If you think of the incidence and prevalence of CKD, global CKD prevalence is already 843 million plus. And if you look at stages 3 to 5, you can clearly see that a huge number of CKD, you see a huge prevalence of CKD in different areas. If you look at the Indian prevalence, data says it's around 6.76%. And why we are so focused on looking at CKD is because if you look at what leads to CKD, 60% of CKD cases have either diabetes or hypertension or both. So 60% burden of CKD comes because of uncontrolled diabetes and uncontrolled hypertension. And as the patient's chronicity increases, which means duration of diabetes increases, you see that the prevalence of CKD starts rising. So if a patient comes to you with 5 years of diabetes versus somebody with 20 years of diabetes, rest assured as time passes, obviously the element of CKD keeps coming in, and with progression of chronicity of diabetes, you will see that the burden of CKD also increases. Now, this is data from Indian Registry clearly telling you that be it east, north, south, west, total, if you look at what are the leading causes of CKD in India, clearly number one is diabetic nephropathy. So uncontrolled diabetes leading to CKD is the commonest reason why patients end up with some amount of CKD in your patient compared to all the other causes of CKD put aside. You can almost see 31.3% of CKD in India is essentially because of diabetic nephropathy, and this is something that can actually be prevented and kind of controlled before the patient progresses to end-stage renal disease, needs dialysis or needs a renal replacement therapy. So this is very, very important that you need to understand how do you screen, when do you screen, who do you screen, and what is the definition of CKD. Well, who to screen? Well, if your patient has type 1 diabetes, you need to screen every year at least 5 years after the diagnosis of type 1 diabetes, because we know type 1 usually occurs in early childhood or in teenage. So 5 years duration of diabetes, if your patient already has, it is essential you start screening this patient for CKD and do an annual screen. Of course, if your patient is a case of type 2 diabetes, screening has to be done right at the time of diagnosis of diabetes, and then at least annually, every year you need to screen this patient for CKD, and maybe more frequently if you pick up some stage of CKD at diagnosis itself. So how to screen? Two important parameters, very, very important that you need to understand. A is a test from urine that you do, simple dipstick, do a spot urine albumin creatinine ratio. And second, when you do a blood test, you do a kidney function test for your patient. And there, based on the serum creatinine or other markers, we have a lot of equations. You calculate a GFR, an estimated GFR. So if your patient has an albumin creatinine ratio, which is more than 30 milligrams per gram, along with or maybe a persistent GFR, which is less than 60, or has some other evidence of kidney damage, that defines a diagnosis of CKD. So a rising ACR above 30, a declining GFR going less than 60, or any other evidence of kidney damage, you know that this patient has some element of CKD present. A single test does not really define CKD. So if you have a single positive test, it is important that you confirm, reconfirm, repeat this test and confirm it again to actually label this patient as CKD, because sometimes there are other causes of proteinuria, such as somebody who smoked, somebody who's done excessive exercise, so many infections, somebody who's just recovered from sepsis, somebody who's got UTI. So there are numerous causes of proteinuria. So you need to repeat the albumin creatinine ratio. And if two tests are giving you a finding which is more than 30 milligrams per gram, and you see some amount of GFR also coming down, then rest assured this is a patient of CKD. So like I said, based on the GFR calculation, you can divide these patients into G1, G2, G3A, G3B, G4 and G5. So more than 90, we say when the GFR is more than 90, you know this is normal. Sometimes in diabetes, early changes, you see a hyperfiltration. So the GFR goes to 100, 110. So that's a hyperfiltering kidney. Then you have CKD2, which means a GFR between 60 to 89. So a mild reduction in GFR. CKD3 or G3 is divided into two categories, 3A and 3B. So a GFR between 30 to 44 is 3B, which means a moderate or severe reduction in GFR. And a GFR between 45 to 59 is a mild to moderate reduced GFR. G4, of course, and G5 are two categories where you have severe CKD. That means a GFR less than 30, that is defined as severely decreased GFR, and less than 15 is actually end-stage renal failure or kidney failure, and these are patients where they need dialysis and eventually a renal replacement therapy. Now, based on albuminuria category, also the amount of protein excretion that you picked up, if the ACR is less than 30, we say it is category A1, that means normal to mildly increased protein. A2 is between 30 to 300, a moderately increased category of albuminuria. And A3, so when the AC ratio, the albumin creatinine ratio is more than 300, you say it is a severely increased albuminuria, and you know that this is severe. This is going towards the severe CKD. So when you have to classify CKD, remember you need to do a GFR estimation and you need to look at the amount, the albumin creatinine ratio. Based on how much is the protein leak, you decide A1, A2 and A3. So this is the heat map, the KDIGO heat map, which puts the patients on the one axis, you have the albuminuria criteria, and on the other axis, the y-axis, you have the GFR categories. So based on what is the GFR and what is the albuminuria category, you map the patient based on his risk. So somebody whose GFR is between 60 to 90 or more than 90, but has less albuminuria. So these are patients in the G1, G2 category with A1 albuminuria. These are patients who are at low risk. Compared to that, if you have a patient whose GFR is declining, even if the albuminuria is less, so again, this patient becomes an increasing risk patient, whereas a patient where GFR may be normal, but he's got more albuminuria, again, that patient's risk increases. So based on the albuminuria category, and based on the reduction in GFR or the reduced kidney function, you can actually label what is the risk of this patient. And accordingly, you map this patient on his follow-up, on his cardiovascular risk and all the other risks of complications, comorbidities and mortality as well. So coming back to Amelia, we started with Amelia. I told you, you've done a calculation and you discover that what is her eGFR, what is her urine albumin creatinine ratio. This is going to tell you whether she has a risk of CKD or not. Mind it, she's got diabetes for last 3 years, but she's uncontrolled and you see her parameters here. So when you do a UACR measurement and a GFR, you calculate her GFR to be 56 and her urine albumin creatinine ratio is 260. So where do you put her on the risk map, the KDIGO heat map? You can see her GFR calculation brings her to the G3A category in terms of GFR. And if you look at the UACR category, she is in the A2 category. So she lies somewhere in the middle. You can clearly see she is orange. So this clearly tells you that her risk of progression of kidney disease as well as premature death, maybe because of CVD or other complications, is pretty high. Of course, somebody whose GFR is in the category of G4, G5, or who's got A2, A3 category albuminuria, these are the highest risk patients. So come what may, whenever you see a patient with type 2 diabetes, even if that patient is not giving you any symptoms or signs of renal disease, keep in mind that you need to do a UACR test for her, do an UACR estimation and do a GFR calculation based on whatever parameters you have. Maybe you use a CKD EPI equation, which is commonly used in patients with diabetes. MDRD was also used, but often now we use CKD EPI. So do a calculation, and most of the lab reports today already give you a calculated GFR. When you tell your patient to go for a kidney function test, you will see that there is an estimated GFR already given there. So based on the eGFR that is there in the report and the UACR, you can put the patient on the heat map and know, okay, this is a ticking time bomb. So what you need to do is try and improve the situation where she is today. And this is where you need good glycemic control, BP management, cholesterol management, and look at her cardiovascular risk also. So for Amelia, now that we've measured her GFR and albumin creatinine ratio, we have diagnosed her to be in a CKD stage 3 with moderately increased albuminuria. Now it is important to understand that any patient who's already at this stage, you know that her morbidity and mortality risk is high. And why I'm saying that is because we know that CKD is progressive. So how does CKD happen? Right in the beginning, when the GFR is still in the normal range or in a hyperfiltering, what you see is a hyperfiltration and renal hypertrophy that happens. And then eventually you see a small slight decline in GFR that takes years to progress. Similarly, in the beginning, your patient may have very less protein, no protein. At the stage of hyperfiltration, protein UACR may still be normal because the GFR is already on the higher side. Eventually, as the CKD starts setting in, you will see microalbuminuria. That means a slight increase in protein. And as CKD progresses over the years, if you do not take measures, you can see that the protein leaks keeps increasing. So from microalbuminuria with normal renal function, eventually CKD will progress to macroalbuminuria or gross proteinuria. And that is when the renal function also starts declining. So the GFR starts coming down. Eventually, when the patient is at end-stage renal disease, you see massive gross proteinuria and a very low GFR. And mind it, all this takes years to happen. So it's not that one fine day patient has microalbuminuria and suddenly he ends up with ESRD, unless until there is some acute assault to the kidney, and I'll come to that in a little while. So remember that CKD is progressive. It takes time to progress. Therefore, at any stage of CKD, if you catch your patient, there is always a chance of giving him some kind of an optimal treatment that can probably delay the progression of CKD, delay the fall in GFR, or probably lead to an improvement in the GFR or a reduction in the protein leak, and that should be our target. So from Amelia, we know that Amelia was also at a CKD risk. Now look at Sushila. Sushila is again somebody who is one of the massive amount of patients with type 2 diabetes, one of the 35 million who already has established CKD. We know CKD in type 2 has a high disease burden. You know, 77 million adults already had diabetes in India. We know the projections were 100 million, but we already know we are more than 110 million now. The latest ICMR in diab study data, if you've gone through that, clearly tells us that this has already been exceeded. We're already 110 million and it's only 2023 now. So imagine the trajectory that we are taking. And out of these 35 million adults already have some stage of CKD. The prevalence of CKD in Indian patients across this population, if you look at the 2017 data, is almost 48%. And this does not mean that all of them have a GFR which is low. Maybe these are patients who have GFR may still be normal, but there is a chunk of patients where you see microalbuminuria, and that is where you need to catch your patient and reverse that. Now, let's look at Sushila. She's referred by her primary care physician to discuss her diabetes management with you. She's a 65-year-old lady. Diabetes duration is 9 years. 29 is her BMI. Now, look at her character representation. HbA1c is 8.7. She already has some amount of peripheral neuropathy as well. Her GFR is already 33 and albumin creatinine ratio is 317. So you know that this is A3 category albuminuria and GFR is also pretty low. So you know she is somebody. Going back to your heat map, where does she fit in? If I show you this, this is where she fits in. So she is already CKD 3B and A3 category, right? So now, if you look at her current treatment, she is on glimepiride 4 milligrams twice a day. So it's like 2 milligrams in the morning, 2 milligrams in the night, along with metformin, 1 gram in the morning, 1 gram in the night. Empagliflozin 25 milligrams. So she's already on an SGLT2 inhibitor, and she's also taking telmisartan for her hypertension. Now, Is there something that you really need to think for this patient? Yes. Like I said, she is CKD 3A2 category. Uncontrolled diabetes are the areas of concern for her. So you need to not only control her sugars, but you need to address the CKD component. So important question that you need to ask yourself is, what will be your target for glycemic control for her? What drug class do you want to add on? Is it only about glucose control alone, or do you also ensure cardio-renal protection? Because now we know that your patient has to be treated by a care me approach. Care me means cardio, renal, metabolic. CAREME. Care me approach. Cardio, renal, metabolic. We know a patient with type 2 diabetes is at a high risk of CKD. And if your patient does develop CKD, her cardiovascular risk also goes up. So you need to address not only the metabolic dysfunction, you need to address the CKD progression, and you need to prevent her from dying of a heart attack, because we know most of the patients with CKD, they do not really die of end-stage renal disease. A large chunk of them dies because of cardiovascular disease. So the implications of diabetes and CKD are manifold. Not only are these patients at an increased risk of long-term complications such as retinopathy, we know CKD and retinopathy go hand in hand. So if you picked up CKD, look at her retina, she will have some amount of retinopathy there. Similarly, it goes the reverse. If you know a patient is diagnosed with diabetic retinopathy, always go back and check her UACR and GFR, and you'll know that there's some amount of CKD present. Similarly, if she's already got neuropathy, foot infections, or any of the other complications, you need to screen for CKD as well. These patients are again at an increased risk of hypoglycemia and DKA, especially when they are progressing towards the severe CKD. Increased risk of kidney failure, need for dialysis if you do not stop the progression there. And like I said, most of the patients with diabetes and CKD have a high risk of CV complications like ischemia, arrhythmias, and heart failure. So what are the anti-diabetic drugs that are recommended when the renal function starts declining? You can see here clearly. When the GFR is more than 60, you can use any of the drugs, any of the doses, they are all safe. But as the GFR starts coming down, you can see the yellows and the oranges and the reds coming in. So this clearly tells you what GFR category, up to what GFR category, which drug is safe for use. You can clearly see, I'll come to this in a little while, and this is where I was talking about. So metformin, I'll talk about this. Very safe when it comes to CKD1, CKD2, even for CKD3. The indication is still a GFR of 30. Once the GFR comes to less than 45, you need to reduce the dose of metformin. If it falls to less than 30, you need to stop metformin because there is an increased risk of lactic acidosis. Again, when it comes to sulfonylureas, you can see here, sulfonylureas, you can clearly see. When it comes to glipizide and gliclazide, usually they do not need a dose adjustment all across the spectrum of CKD, but of course in end-stage renal disease, you need to use them with caution because of an increased risk of hypoglycemia. All the other sulfonylureas, including glimepiride, usually you need to stop them once your patient is at CKD 3B progressing to CKD 4. Again, the meglitinides, ripaglinide and natiglinide up to about CKD4, they can still be used, but there is very limited data when it comes to CKD5 or end-stage renal disease. Alpha-glucosidase inhibitors less than 30, you need to avoid them. Same applies for miglitol. Glitazones again, although when it comes to CKD, they are found to be safe, but towards the severe spectrum of CKD, you need to be careful with pioglitazone because obviously of the risk of water retention, fluid retention, and all those other fluid overload associated with glitazone. So you need to be a little more careful in the severe CKD. Gliptins, sitagliptin, saxagliptin, vildagliptin, we all know dose needs to be reduced to half at CKD3. And for sitagliptin, you have data of dose reduction up to 25 milligrams once a day in severe CKD. Linagliptin is the only gliptin which has been found to be safe all across the spectrums of CKD. So this is a safer gliptin when it comes to which gliptin can be used in CKD patient. Again, allogliptin dose needs to be reduced once the GFR falls less than 45. And then usually towards the severe stage of CKD, linagliptin is the only gliptin that can be safely used. Sitagliptin 25 milligrams. There is data even in some studies in dialysis also, but we prefer using linagliptin. Prudence. You need to use your prudence when it comes to which drug you want to prescribe. Again, when it comes to the GLP-1 agonists, we know they can be safely used, but doses need to be reduced. And again, once the GFR starts falling, although there are studies that show GLPs are safe, but then the gastrointestinal side effects, because once CKD advances, patient will already have reduced appetite, patient will already have vomiting and nausea. So there you need to use these drugs with caution. So this is what I was going to talk about. Metformin, severe risk of lactic acidosis. Therefore, GFR less than 30, you need to stop metformin. GFR between 30 to 45, you can use half the dose of metformin that your patient was using. DPP4s, like I said, except for linagliptin, all the other gliptins, you need to reduce the dose to half. And for sitagliptin, they say reduce it to 25 milligrams. But of course, renal monitoring is a very important component when your patient is on any of the other gliptins except lina, which can be used even up to dialysis. GLP-1s, again, I told you, they do have a potential for altered renal function. So you need to use them with caution, especially in patients with severe renal impairment or ESRD. Again, the GI side effects usually will contraindicate them. Your patient may not be able to tolerate these drugs in advanced CKD. Sulfonylureas and glinides, of course, as the CKD progresses, there is an increased risk of hypoglycemia. So you need to do a good dose adjustment. And of course, renal monitoring is important. Drugs like glimepiride, low dose may still be used at a GFR of about 45, but less than 30, you need to use them with caution, except for glipizide and gliclazide, where there is some data where they have been found safe. But again, like I said, low doses only. SGLT2 inhibitors, there is data till up to GFR of about 25 now. 20 also there are some studies, but the label says a GFR less than 30, they are contraindicated. That's because the risk of AKI is also increased. And again, like I said, they stop working. The efficacy goes down when it comes to glycemic reduction. Although SGLTs, I'll show you the data in the next few slides, have been recommended in CKD because they reduce the progression of CKD, and we've seen excellent results with SGLTs all across the trials. If you look at the empagliflozin trials, the dapagliflozin and the CANA trials, the EMPA-REG, the DAPA kidney, the EMPA kidney, all these kind of DAPA CKD trial, all these trials have clearly shown that up to a GFR of 30, SGLTs actually give your patient a lot of renal protection and renal benefits. Glitazones, like I said, use them with caution because of the risk of fluid retention, heart failure, weight gain, and bone fractures. Alpha glucosidase, again, less than 30, they are contraindicated in severe renal impairment because of the modest glucose lowering effect. And obviously, like I said, again, with AGIs, GI intolerance is a very, very important factor you need to account for, especially in patients with severe renal disease. Insulin is the safest agent when it comes to patients with CKD. But again, like I said, the pharmacodynamics of insulin also change in CKD patients. So there is an increased risk of hypoglycemia. So a careful dose adjustment based on the SMBG is very important when your patient is on insulin. So when it comes to the progression of CKD, except for SGLT2 inhibitors and some amount of benefit seen with GLP receptor agonists, most of the other agents are neutral when it comes to having any effect on progression of CKD. Some drugs such as glitazones and all, you need to be very, very careful about because they increase the risk of heart failure, especially when your patient has CKD. Be very careful when your patient is on a glitazone. Usually it is, prudence says you should avoid it at that stage. Metformin, like I said, neutral when it comes to reducing the progression of CKD, but otherwise metformin is safe up to about 45. Beyond 45, less than 45, you need to use half dose of metformin, maybe 500 milligrams once a day. Less than 30, better to stop. So what do the current guidelines recommend for treating patients with type 2 diabetes and CKD? If you look at the KDIGO guidelines, they again say first line should be an SGLT2 inhibitor because of the renal benefits, plus metformin when your GFR is more than 30. ADA also says it is better to use an SGLT2 inhibitor or a GLP-1 in patients with CKD, independent of the baseline A1C individualization target or metformin use, because of obviously the benefits that we have seen in terms of reducing the progression of CKD with SGLT2 inhibitors and to some amount with GLPs. The PCDE guidelines, the European guidelines also recommend metformin as the first line along with an SGLT if your patient has CKD. So this is the ADA algorithm. I need not go into the details. I think all of you have seen this. Clearly tells you that if your patient has CKD and your goal is not only glycemic reduction but also a cardiorenal risk reduction, because this is a high risk patient with type 2 diabetes, then for this patient you need to exercise prudence and prefer an SGLT2 inhibitor that has a primary evidence of reducing progression of CKD in terms of improving the GFR and improving the UACR. So for these patients, when GFR is more than 20, you can use an SGLT2 inhibitor. Of course, it should not be initiated at a GFR of 30. Once initiated, it should be continued until patient goes to dialysis or transplantation, or you can also use a GLP if SGLT is contraindicated or not tolerated. And then if the A1C is above target, you can go for the other agents based on what you need. If you need glycemic reduction, you have drugs that have high glycemic reduction, such as the GLPs, you can use insulin. And otherwise, some DPP-4s that have an intermediate efficacy when it comes to the HbA1c reduction, linagliptin being the safest in CKD patients, or maybe a low dose of the other gliptins can be used. And then come the other drugs. So this is the KDIGO 2022 algorithm for selecting the anti-hyperglycemic drugs for your patients with type 2 diabetes and CKD. Like I said, lifestyle remains most important. Talk to your patient on physical activity. Talk about the importance of weight loss if your patient is obese. Talk about nutrition. And then first line therapy has to be metformin along with an SGLT2 inhibitor. And then if the patient needs additional drug therapy, in order of preference, you need to look at the patient preference, look at his pocket, look at the comorbidities that the patient has, what is his current GFR, what is the trend of his GFR decline, look at the cost, whether he can afford the expensive therapies or you want to give him something which is more pocket friendly. And that is where GLP comes in as the agent of choice if your patient can afford and tolerate. Otherwise, you can use a DPP-4 inhibitor or insulin. Of course, SUs come a little lower in the algorithm. AGIs, I told you, tolerance issues can happen, not to be used at GFRs less than 30. And glitazones also, although they are safe in terms of CKD patients, but fluid retention could be a good problem here. So this is the metformin algorithm that I was talking about. Less than 45, reduce the dose. Less than 30, stop metformin. So it is important to sum up that in patients with type 2 diabetes, kidney function has to be monitored at regular intervals, at least once a year. So you need to do a UACR estimation and a GFR calculation. In advanced CKD, hypoglycemia can be a big concern. So that is where an HbA1c target of less than 7% may have to be relaxed. So if your patient is on SUs or insulin and is already on stage 4 or stage 5 CKD, you need to you need to improve his glycemic control, but do not give him very tight control at the cost of hypoglycemia. So even up to 7.5 or even 8 in end stage can be acceptable, specifically now when we have newer agents like SGLT2 inhibitors that do not cause too much of a hypoglycemia. So you can take him off the SU, put him on something like an SGLT, or you can use insulin and you can titrate the doses of insulin based on the patient profile. And while there is a broad consensus that I showed you with the different global guidelines, individualization is the key when setting the target for your A1C. For your individualized patient. Exercise, of course, if your patient can do it, a 30-minute daily exercise must always be done. And sedentary lifestyle has to be kind of circumvented. Now, acute insults, I told you, normally if you look at the progression of CKD, it almost takes about 25 years of diabetes leading to CKD, progression of CKD, and ending up with end-stage renal disease if it is progressing naturally. But if you have an acute kidney injury through maybe some drugs, obstructions, infections, dehydration, uncontrolled BP, then this gets fastened, and acute kidney injury, your patient can land up immediately with end-stage renal disease, and this could be life-threatening unless until you initiate renal replacement therapies in terms of either a dialysis or a renal transplant. So drugs that you need to avoid are all nephrotoxic drugs. So if your patient is on painkillers, taking some Ayurvedic, herbal, Unani medicines, avoid unnecessary contrast studies, CT angiograms. You need to counsel your patient on being very careful on what medications he's taking. Sometimes patients keep taking Overon, diclofenac, those kind of drugs, which can actually fry their kidneys. So when your patient is already in ESRD, this is again linagliptin. There is data which shows that linagliptin can be used in renal compromised patients. Even low dose repaglinide or glipizide may be used. However, insulin remains the treatment of choice. Preferably when the GFR is less than 30 or your patient is on dialysis, they will just need a rapid acting bolus insulin. Basal may actually not be required unless until you see a patient whose fastings are also high. Once ESRD occurs, insulin dose needs to be reduced to 50% than that the patient was taking earlier, and SMBG is going to be your guide when it comes to titrating insulin doses. So there's no fixed regime as such. Both the ADA and KDOQI clearly tell you there is no regime, but it is all based on the GFR calculation, and you can accordingly reduce the dose by 25% to even 50% as the GFR declines. So with that, we move on to CLD, chronic liver disease. That's again something very, very important. A lot of patients these days come with CLD. An important challenge that you need to understand with CLD is half of your patients will be malnourished. Patients do have a lot of hypoglycemia because obviously CLD, the glucagon reserve goes away. The glycogen reserves are gone. So the glucagon response is also gone. So usually these patients will have episodes of hypoglycemia. Many times when the patient is diagnosed with CLD, already he is at an end-stage liver disease because the symptoms come in very late. And most of the oral drugs are metabolized in the liver. So if the liver is not working well, this could be a huge concern, and you really need to modify therapy when it comes to a patient who's got CLD and he's already diabetic. So CLD alters drug metabolism. There's impairment of metabolism in proportion to the liver dysfunction. There'll be numerous metabolic alterations, essentially catabolic changes happening in the body. The hepatic blood flow, liver enzyme activity, plasma protein concentrations will be impacted. Again, most of the drugs are metabolized by the cytochrome P450 enzyme system. So again, bioavailability of the drugs is going to be hugely impacted. So if your patient has CLD, remember, you need to review the drugs that he is on because of all these factors. Glycemic targets, again, there are no specific guidelines which talk about what should be the targets in CLD. So targets need to be individualized. Now let us look at the pros and cons of various anti-hyperglycemic medications when it comes to your patients with CLD. Looking at metformin, we know that metformin is indicated safe in patients with CLD, rather even in patients with cirrhosis. If the patient has compensated cirrhosis and is stable, it reduces the risk of HCC by almost 50 to 70%. Metformin is a great drug which reduces the insulin resistance. And we know CLD, there is marked insulin resistance. So this is one drug which has favorable safety profile. It is cardioprotective. It improves insulin resistance, reduces aminotransferase levels, and also has a role in improving liver morphology in patients who have NAFLD. Again, like I said, risk of hepatic encephalopathy is also reduced by 8-fold if your patient with stable CLD is given some dose of metformin. Therefore, studies have shown that even patients who have stable cirrhosis compensated CLD, if you continue metformin in these patients, overall median survival also increases. But one caution that you need to exercise is a metformin-associated lactic acidosis. So there is a slight risk of metformin-associated lactic acidosis. So if your patient decompensates, that is where you need to stop metformin for these patients. Otherwise, metformin can be given in especially category A, B, and even C. I'll show you that. Glitazones, again, pioglitazone is one drug which has been found pretty safe. It inhibits HCC development in experimental rat models, has a low risk of hypoglycemia, has been shown to improve aminotransferase and liver histology. But there are long-term safety concerns, and of course the concern of weight gain with pioglitazone along with fluid retention. So again, prudence needs to be exercised when writing something like a pioglitazone for your patient with CLD. Alpha glucosidase inhibitors, of course, the only problem is flatulence and diarrhea. They reduce postprandial hyperglycemia. We all use them as postprandial agents. They reduce glycemic variability. They also have a role in improving the serum ammonia levels and improving intellectual function for your patients. And they may reduce hepatic steatosis in combination with ezetimibe in experimental models. So again, something to look for. GLPs, we know they reduce weight, they have a low risk of hypoglycemia, they improve hepatic insulin sensitivity, they improve aminotransferase levels, have beneficial effects when it comes to NAFLD and NASH patients, so improvement in steatosis and fibrosis scores. They may inhibit alcohol consumption in some experimental models, but this is still very, very experimental, very initial data. And the only problem is in advanced cirrhosis, when your patient already has nausea, reduced appetite, vomiting. So there, of course, their use is not really found to be, because of the tolerability issues, not really safe. And we have limited data in these patients. So you need to exercise prudence, like I said. Gliptins, DPP4 inhibitors, we know they are weight neutral. They have a low risk of hypoglycemia. Some models, they've shown reduction in hepatic inflammation. Some experimental models may be inhibition of HCC development. But again, heart failure is something where we'd had those allogliptin, we had some concerns. Even with saxagliptin, we had some concerns. So CLD, you need to be a little more cautious. And in advanced cirrhosis also, there is limited experience available. So ideally, best is to go on to insulin. SGLT2 inhibitors, again, we are getting some data on improvement in liver markers, especially in patients with NAFLD and NASH. So SGLT2 inhibitors also have some beneficial effects in patients with NAFLD and NASH. But of course, advanced cirrhosis, we really don't have data. And again, you need to be very careful because of the increased risk of UTI and GTI. So in advanced liver disease, maybe child category B or C, using an SGLT, landing up the patient with some kind of infection which can push the patient towards hepatic NCAF, you need to be very careful. But early CLD, pretty safe. Sulfonylureas, I told you, increased risk of hypoglycemia. And as it is a CLD patient, his glycogen reserves are gone. So sulfonylureas are drugs that you need to be little more careful if your patient has CLD. I would advise refraining from sulfonylurea or using a very low dose of sulfonylurea. Insulin has been found to be safe. Use it with caution based on the SMBG, because again, insulin has a high risk of hypoglycemia. Moving on to liver cirrhosis. This is how you manage. Like I said, lifestyle interventions and all those are very important. If your patient has stable cirrhosis, if your patient is stable and HbA1c is less than 10, glucose levels are less than 300, this is a common algorithm which clearly tells you that you can continue low dose of metformin, and accordingly, based on the preference, if you need to use any additional drug, you can probably prefer an SGLT2 inhibitor because of the weight benefit, also renal safety also. And then if your patient can afford and can tolerate, and a GLP-1 can be the next in line. Otherwise, a DPP4 may be used, but you need to avoid sulfonylureas, you need to avoid pioglitazone, even GLPs, like I said, you need to avoid because of the GI intolerance, especially when your patient already has renal dysfunction, also along with CLD, especially when the GFR is dipping. And obviously, encephalopathy is one stage where you need to use only drugs that improve encephalopathy. And this is where there is some data with AGIs. But again, data is very less. And of course, glycemic targets have to be much more better. You don't want tight glycemic control with the patient ending in hypoglycemia. So you can lower or relax the glycemic targets and give agents that have less hypoglycemia risk. Of course, if your patient has acute event, sepsis, bleed, encephalopathy, hepatorenal syndrome, glucose levels are high, insulin and insulin alone has to be used. So this is the different categories based on which drugs can be used at which stage, which I told you. So in cirrhosis, better to avoid sulfonylureas and meglitinides. Child A and child B, glitazones, you need to be very, very cautious in all categories of CLD. So only if it is a stable patient, you may continue a low dose pioglitazone, but otherwise, because of the risk of fluid retention, heart failure and osteoporosis, you have other options available. Go for those options. Gliptins, I told you, Vildagliptin is one agent that raises liver enzymes. So if you are having any category of CLD, especially B and C, you need to use these with caution. Avoid them in category C. Vildagliptin is not to be used. GLP is, again, I said, so child A, most of these agents you can use. Child B, use them with caution. Child C, I think insulin is the safest. Moving on to the third situation, special situation, which is diabetes in the elderly. So this is where, again, you need to be very, very cautious, because elderly patient is very different from your normal young type 2 adult. Now let's talk about Shamlalji, a 72-year-old diabetic, 13 years of diabetes behind him. He stays alone, children working in the Gulf. Ejection fraction is low. He has CAD. He's had an MI in the past. He's already had an episode of lymphedema. He's overwhelmed by a number of medications. He takes medicines for his heart. He takes medications for his BP. He's on anticoagulants, and he's on drugs for his diabetes control. You can see he's on metformin 500 milligrams twice a day. He's on glimepiride 2 milligrams twice a day with sitagliptin once a day. You can clearly see he's not on good glycemic control. His A1C is 10.1. Fasting and postprandials both are much above the target. Looking at his BMI, he's of course overweight, 28.1. Creatinine is 1.7. So he's got a GFR of 46 and a urine albumin ratio of about 50. So again, this is somebody who's already got some amount of CKD also. Now, how do you manage this patient? When you see an elderly patient, what are the important concerns that you need to have in mind when you decide on what treatment to follow? Remember, diabetes is a very, very common health problem in the elderly. So many people are diagnosed with diabetes once they start aging. Number of deaths in the elderly between 60 to 99 years was almost 32 lakhs, which is about 60% of the deaths due to diabetes in this age group. And we know India is the diabetes capital of the world. But if you look at the number of people who are more than 65 years of age, 12.1 million are diabetic. So this number is expected to go up to almost 30 million by 2045. So what is the definition of elderly in the first place? Well, the ADA says any adult who is more than 65 years of age is to be called an elderly diabetic. The IDF and even the Indian RSSDI, our organization, says anybody above 70 is to be labeled as an elderly, and you need to look at these patients with caution. Why? Because there is a link between diabetes and aging. Diabetes increases the risk of sarcopenia and frailty in these patients. So likelihood of frailty goes up in these patients. And one important thing that you would have all noticed if you've seen an elderly diabetic is increased risk of depression, which again reduces compliance to medications. Again, if your patient has frequent swings in blood glucose control, that means hypoglycemia or hyperglycemia, there is a clear-cut evidence that persistent hyperglycemia or recurrent hypoglycemia increase the risk of cognitive dysfunction and dementia by twofold. So if your patient has glucose levels going up or down, or he's uncontrolled diabetic, his mental and cognitive disabilities can be a huge challenge to diabetes management, because this compromises his self-care, increases his dependence on his caregivers, and of course, if the patient is not compliant or is landing up with complications, the risk of complications reduces his quality of life further. Again, because of visual problem, hearing problem, there will be a lot of physical disabilities, joint mobility goes down, they have arthritis, they have so many other problems. So all these activities of daily living, they may be dependent on the caregiver. So even taking insulin or checking glucose with a glucometer could be a challenge for many elderly patients. So your regime has to be something, your treatment has to be something that keeps all these things in mind. So when it comes to the complications in elderly with diabetes, remember his mental dysfunction also has a role to play when it comes to progression of complications. Patient with dementia, depression, behavioral or anxiety disorders. Again, patients who are sarcopenic and frail, patients who have proximal motor neuropathy. You will see a lot of patients with tremors, patients who got vascular disease, micro or macrovascular. They've got neuropathy, retinopathy. They've got, macrovascular disease, cardiovascular disease, stroke, PVD, foot disease. So all of these, along with physical disabilities such as, reduced vision, reduced hearing, immobility, frequency of falls, all of these things have to be kept in mind when you decide on what treatment regime you want to give to your patient. So diabetic who is elderly may not really come to you with clear-cut symptoms of diabetes, because for these people, osmotic symptoms may be less prominent. 50% of the older patients may actually be asymptomatic, and you do a glucose test and you discover that they have diabetes. Non-specific symptoms, they say, I'm fatigued, I'm tired, I'm lethargic. So we think, okay, he's an old man, so he's tired, and this could be diabetes which is masked, which you've not picked up. Again, patient may present with visual loss. You think that it is because of cataract, not knowing that this could be retinopathy in the background. Patient comes to you with, some kind of immobilization, and you don't think about neuropathy. Falls may be a common presentation of diabetes. So why should your approach be different is because of all these concomitant geriatric syndromes, varied expectations of self-management with aging and increasing frailty. Again, so many times, the children are living separate from their parents. The elderly people are living alone or are dependent on some caretaker, maybe on a maid or a full-time servant who's looking after them, or they are in a old age home in a community living. So these are very important factors you need to keep in mind when you decide on what treatment regimes to follow. And of course, the clinical and functional heterogeneity of elderly patients. On the one side, you will have a 60-year-old man who is confined to bed. On the other side, you will have an 80-year-old man who's running around freely active. So your treatment for that 60-year-old versus this 80-year-old will be very different. So it is important that you categorize your older people with diabetes into categories. So the first category is somebody who is functionally independent, irrespective of age, can look after himself. Category 2 is somebody who's functionally dependent on the caregiver. And category 3 is somebody who's completely bedridden with lot of comorbidities and complications. And this is somewhere you have to provide only an end-of-life supportive palliative care to these patients. So remember, look at your patient, decide what category is he in. Is he functionally dependent in terms of physical disabilities? Does he have some amount of frailty? Is he somebody with dementia and depression who cannot look after himself? So looking at the heterogeneity, main categories will be used for your clinical decision making. Look at his activities of daily living, divide him, and then decide on the glycemic targets. So if you look at the IDF glycemic targets, you need to take into account the functional status of the gentleman, his comorbidities, especially established cardiovascular disease. Look at the risk of hypoglycemia and whether he's got frequent episodes of hypoglycemia. Look for the presence of other microvascular as well as macrovascular complications. So if your patient is somebody who is elderly in terms of age, but is otherwise functionally independent, does not have too many complications, why not give him a good quality of life? So you can go for good glycemic control, aim for an HbA1c of 7 to 7.5. If your patient, irrespective of his age, he may be 60, he may be 70, he may be 80, is functionally dependent, then you need to loosen the glycemic control. So anything between 7 to 8 can be good for him. Of course, if it is a frail elderly person, you can relax even up to 8.5% as per the IDF. And if see somebody with dementia who does not even look after himself, does not even remember things, who cannot look after himself, for these patients up to 8.5% is also acceptable. Of course, if it is somebody who is at the end of his life, so for him, all you need to do is give him a good quality of life for as long as he's alive, for whatever remaining time he has. So all you need to do is avoid symptomatic hyperglycemia. Do not go for tight glycemic control. Do not push him into hypoglycemia, because that can end his life. So these are the treatment goals, and this is exactly what the ADA says. And again, these are the RSSDI, our own Indian recommendations, which clearly tell you that if the patient does not have cognitive impairment, if he is independent, looking after himself, general health is pretty good, and does not really have major comorbidities and complications, and you know that he's going to live for another 10-15 years, give him a good quality of life, aim for an HbA1c of 7 to 7.5. On the other hand, if your patient has some amount of cognitive impairment, you see that he's dependent on his children or caregivers, his general health is neither very poor but not very good, he's somewhere in the middle, he's maybe got some complication here or there, he's got some amount of frailty, and you know that, he's just got another 5-7 odd years of life expectancy, loosen the glycemic control, let it be 7.5, in even up to 8 or 8.5 if he's got too much of hypoglycemia. And of course, the other end, somebody who's bedridden, dependent on others, with advanced comorbidities and complications, with poor health, dependent on others, and severe cognitive impairment, where you know that this patient just needs to go away peacefully, give him a loose glycemic control even of 8.5 and above. So this is what the RSSDI ESI consensus recommendations say, and I've been part of this consensus. So there are a lot of challenges when it comes to managing elderly patients: altered PKPD of drugs, dependency on others, cognitive impairment, concomitant diseases, visual and auditory impairment, increased risk of hypoglycemia, polypharmacy because of multiple drugs. They are taking drugs for dementia, drugs for Alzheimer's, they are on hypertensives, they are on drugs for CKD, drugs for CLD, sometimes irregular diet, they are dependent on their caregiver to give them food, psychosocial impairment. So all these are important challenges that you need to circumvent. So what about the oral agents for elderly patients? When it comes to metformin, of course, it is a very safe agent, especially if your elderly patient is also an obese diabetic. But remember what I told you, if he's got CKD, that is where you need to reduce the dose. If the GFR is less than 45, make it half. Less than 30, stop the drug. Sulfonylureas, better to use low doses, especially use the meglitinides, which are short acting. Quick in, quick out, those kind of drugs are better. Alpha glucosidase inhibitors can be given to elderly unless until they have too much of bloating or nausea or gastritis. Otherwise, AGIs do not cause hypoglycemia and they can be given for good postprandial control. Glitazones to be avoided in elderly. I would definitely say anybody above 60 years of age, avoid a pioglitazone unless until there is an indication to use because of increased risk of fluid retention, osteoporosis, frailty, heart failure. Gliptins can be safely used. We all know that. They are renal and kidney friendly, heart friendly, except vildagliptin in CLD, where it should not be used. And like I told you, if your patient also has CKD, you need to reduce the dose unless until it is a linagliptin, which can be used. GLPs, again, in obese diabetics are good drugs if your patient can tolerate, even if he is elderly. There is data of almost 70-year-old. There are studies with elderly patients also with GLPs where they have been found to be safe, can be used unless until GI disturbance stops it. SGLT2 inhibitors also are recommended. There is data which shows even in 70 to 75-year-old patients where SGLTs have been used safely because of all their cardio, renal and metabolic benefits. And they are also helpful in patients with heart failure, both systolic as well as diastolic dysfunction. So can be safely used. Obviously, somebody who's got too much of osmotic diuresis, somebody who is not on a good diet, sick patient, patient eating less of carbs, patient who is having recurrent UTIs or GTIs, patient who is insulinopenic, patient who is frail, there you may not use an SGLT2 inhibitor, otherwise they are pretty safe. When it comes to injectables, insulins can be safely used. For elderly diabetics, now we have longer acting basals like degludec and glargine U300. So these drugs cause very less hypoglycemia. So these can be used safely for elderly. Otherwise, you can use any of the other short acting or rapid acting prandial insulins also to cover the prandial peaks. So these are safe. Premix insulins can also be used, but then dose titration sometimes becomes difficult for these patients. So I think with that, I'll stop here. And then I'll request all of you to put in your questions or comments if you have any, and we can take up some questions. You can put your questions in the chat box and we can have about 5 to 10 minutes of discussion before we log out. So, well, I have this question from Dr. Niladri. Why elderly diabetic patients are prone to take sleeping pills? SUs are prone to develop insomnia, but patients on other OHAs also complaining same. How to deal it without meds apart from sleep hygiene? Well, SUs do not really lead to insomnia. That is first thing. I am sorry, I have never come across a study which shows that SUs cause insomnia. The only reason why elderly patients are prone to take sleeping pills is because they come to you with complaints of insomnia. With age, sleep does reduce. We all know that. Minimum 6 hours of sleep is required. We know the J-shaped curve, which tells you that a sleep of less than 6 hours or more than 12 hours is harmful. So it increases the cardiovascular risk. So therefore, it is important that your patient has at least 6 to 8 hours of continuous sleep. Now, with age, the circadian rhythm also changes because of the hormonal disturbance. So therefore, for elderly patients who complain of sleep disturbance, sometimes difficulty in falling asleep or staying asleep or waking up early morning, for them, it is better to give them a safe low dose sleeping pill. Nowadays we use a lot of melatonin also because it resets the sleep cycle for these patients, so it's a very safe option. It is non dependence causing drug which can be used to reset the circadian rhythm, the biological clock. So melatonin can be a safe option to be given to elderly patient. You can start with 3 milligrams at bedtime, and then if required may increase the dose a little if your patient is not responding. Otherwise, a low dose sleeping pill can also be prescribed as long as it is safe and the patient does not have any contraindication in terms of a CKD or a CLD. Any more questions? Let me just go through the chat box. Okay, ma'am, do you suggest using SGLT2s in type 1? Okay, now this is out of what we are talking, what I talked, but let me give you a straight answer. There is off-label data on off-label use of SGLT2 inhibitors in patients with type 1 diabetics, essentially because of the cardiorenal benefits that we see. A lot of patients these days with type 1, as they gain weight, they also develop some kind of presentation of insulin resistance. So there is off-label SGLT being used in some trials, some studies, but as of today, there is still no guideline or no recommendation for use of SGLTs in type 1 diabetes. Again, you need to be very careful with SGLTs, especially in patients with type 1 diabetic, because they are prone to ketoacidosis. So with SGLT, we know euglycemic DKA is also a very common presentation because of the ketogenesis that these drugs can cause. So use them with lot of caution. My personal advice would be, till we have a clear indication, you should not be prescribing an SGLT2 to any patient with type 1 diabetic. Now there's another question on, can we give metformin in pregnancy breastfeeding for diabetes treatment? Well, this is again, I did not touch upon pregnancy, but maybe you can go back. I did record a lecture on GDM. It will be available somewhere in the database. You can go through that. In short, let me tell you, metformin has been found to be safe in pregnancy. In PCOS patients or obese patients, there was studies which showed that metformin could delay progression to GDM, but now there is a lot of data coming in with more evidence which shows that this does not happen. So if you look at the global guidelines, they say in pregnancy and breastfeeding both, insulin is the drug of choice. Insulin is the gold standard. But in situations where insulin cannot be used, for example, your patient is in a village, your patient cannot take insulin, is not accepting insulin, and you need tight glycemic control, metformin can be used. But the problem is some studies like MITI study in type 2 diabetes where metformin was used all through pregnancy, and a follow-up of MITI, the MITI kids study that just came out few weeks back, or a lot of other studies have shown that children who were exposed to metformin intrauterine were born small for gestational age. Then they had a catch-up growth. And by the time they were followed up, we have studies of almost 11 years follow-up, which have shown that children exposed to metformin when they were intrauterine, in the womb, these children tend to be more adipose. They tend to have more waist circumference. They tend to have higher BMIs and more prone to metabolic disorders as they grow up, more prone to obesity and developing diabetes. So you need to use metformin with caution. The DIPSI guidelines, the Indian guidelines, and I happen to be a governing council member of DIPSI, clearly say that metformin has been used for ages. A lot of our gynecologists and obstetrician colleagues, they swear by metformin safety. So in India, metformin has been prescribed in pregnancy and has been continued in pregnancy. So if the patient has very mild degree of dysglycemia, metformin can still be used with caution. But if the glucose levels are still not on target, and what is the target in pregnancy? A fasting has to be less than 95 and a 2-hour postprandial has to be less than 120. So if your patient is on metformin, but the fasting is still more than 95 or the postprandial is still more than 120, the 2-hour post meal, then patient has to be given insulin and insulin alone. That is very, very important. If your patient has a risk of IUGR in pregnancy, if she's got preeclampsia, if she's got any contraindication, if she's losing weight or she's a high risk pregnancy, then you should not use metformin. Metformin is contraindicated in these situations and their insulin alone should be used. When it comes to breastfeeding, again, metformin has been found to be safe. Metformin crosses the placenta, metformin crosses the breast milk, but the plasma levels of metformin in the baby who is being breastfed are very less. And we still need some data on whether it has any impact on the baby. As of now, it has been found to be safe in clinical experience. So you need to use your prudence when it comes to using metformin in pregnancy. There's another question on, is there any difference in NAFLD and MAFLD? No. MAFLD is the new term that is being used for NAFLD. NAFLD was non-alcoholic fatty liver disease. MAFLD is metabolic associated fatty liver disease. Why did this nomenclature change? MAFLD is a very new nomenclature for the same NAFLD that we were using, because we see that patients with non-alcoholic fatty liver disease, the term alcohol is a taboo. It's like patient is like, I don't even drink. And you're calling this a non-alcoholic fatty liver disease. Again, the term was used because most of them will have metabolic syndrome. They will have a lot of other metabolic abnormalities in terms of dyslipidemia, TG going up, LDL going up, HDL coming down. They will have abdominal obesity. They will have all the other insulin resistance markers. So there is metabolic associated liver disease. Fatty liver, all these things will happen. So that is why now we use the new term called MAFLD, which is kind of a NAFLD with all the other metabolic dysfunctions roped in. So we use the term MAFLD. Treatment is essentially the same. Most important treatment we know for MAFLD or NAFLD is weight loss. Tell the patient to lose weight, good MNT, fat restricted diet. Drugs do not have major role. Insulin resistance has to be taken care of, which again happens with weight loss and physical activity. Some drugs like vitamin E, saroglitazar have been tried, but we really do not really have some major drug per se for MAFLD. A lot of other drugs are in the pipeline. Maybe we'll cover that in some other lecture. So which OHAs are best to be given in combination with insulin? Okay, basal bolus insulin. If your patient is already on basal bolus, means he's on 4 shots of insulin. If he's obese, you can add on a metformin. If you want to give him a cardiorenal protection, you can add on an SGLT2 inhibitor also. Again, a gliptin can also be used along with insulin. So these 3 can easily be used. If your patient has a huge amount of insulin resistance and he needs very high insulin doses in type 2 diabetes, maybe a low dose sulfonylurea we use in most of our Indian patients also. The Western guidelines say if your patient is on basal bolus, there's no role of sulfonylureas. But now there is data which shows that when you use a sulfonylurea, what is it doing? How does it work? It increases the intrahepatic, it goes through the enterohepatic axis. So the beta cells are also stimulated to release insulin. The insulin that you take from outside does not enter the enterohepatic circulation. Whereas if the body is producing its own insulin, even if it is producing less, it enters the enterohepatic circulation also. So it gives an added advantage in improving the glycemic control. So a small dose of sulfonylurea, especially if it is not very late chronic diabetes, can also be combined with a basal bolus insulin regime. So you have to use your prudence, look at the clinical presentation of the patient. What are his comorbidities? What are his coexisting conditions? What is his dose requirement? What is his daily routine? And then you can mix and match the agents. The only agent that should not be used with insulin is a thiazolidinedione, which means a pioglitazone. Glitazones ideally should not be used along with insulin because they cause water retention, fluid retention. So therefore, don't prescribe a pioglitazone if your patient is on insulin, because it will lead to immense weight gain for that patient. We know that insulin per se also leads to some amount of weight gain, but if you use a glitazone along with it, weight gain, water retention is going to be massive. So only drug that should not be used with insulin is a glitazone. All the other drugs, even sulfonylureas, low dose, can be added. Others you can use safely based on the patient profile. DKD versus CKD differences. Okay, this is another question. Well, CKD is any chronic kidney disease. It could be because of diabetes when you call it diabetic kidney disease. It could be NDKD, non-diabetic kidney disease. That means the CKD or the GFR decline or the proteinuria or the kidney dysfunction is because of other reason other than diabetes. This could be hypertensive CKD. This could be due to glomerulonephritis. This could be autoimmune nephritis. There are so many other causes of CKD. So CKD is a broad term, chronic kidney disease, and based on what is the etiology, what is the cause of that CKD, whether it is diabetes, you call it diabetic nephropathy or DKD or diabetic kidney disease. If it is not because of diabetes, then it could be any of the other CKDs. So a common thing that if your patient has diabetes and he develops CKD, don't assume that this is only DKD. A patient with diabetes can also develop non-diabetic kidney disease. So if you, I remember I told you, I showed you that graph where I said that DKD progresses very slowly over a number of years. If your patient's diabetes duration is very less and suddenly you see a sharp decline in GFR, or you see you do a urine test and you see sediments there, you see casts there, so that all points to there is no retinopathy. If you've done a retina and there's retina is perfectly clear, so all these things tell you that this could be a non-diabetic kidney disease. So a sharp decline in GFR, absence of retinopathy, presence of urinary casts and sediments, some other precipitating cause, this could be a non-diabetic kidney disease also. So don't, just because patient is diabetic, not every nephropathy is diabetic nephropathy. So you need to watch out for that. Any more questions? I think I've addressed all the questions that were there in the chat box. If there's anything else, I'll be happy to take that. There's a request for a PDF of this session. I'm not sure. I think the daily rounds people can enlighten you on that. There'll be a recording available, so you can always go back and listen to the recording. Ma'am, what is the use of C-peptide levels? Well, C-peptide levels are essentially done to look at the insulin reserve of your patient. So, you know, if you are maybe trying to take a decision on whether this patient needs insulin, is insulin dependent or not, you want to differentiate whether it is type 1.5 diabetes or type 2 diabetes, whether it is LADA or type 2, you can do a C-peptide. But remember, if your patient already has a glucose level which is more than 250 or 300 plus, 250, 300 plus, then sometimes because of glucotoxicity also the C-peptide levels will be low. So this could be false low. So ideally you should do a C-peptide, especially when it comes to patients with type 2 diabetes. There you should do a C-peptide only when the glucose levels are a little better. Then you will get to know how much is the insulin reserve. And okay, so I find this link on glimepiride and insomnia. Thank you so much, doctor. I'll definitely go through this and revert back to you. This is something new to me also. Regular and but let me tell you from my clinical experience of last 20 years, I don't really, this could be just an isolated case study or an isolated finding. There is no major scientific paper or scientific study on this, but yes, thank you for the link. I'll go through it. So I think we've addressed most of the questions. When do we use PPAR alpha agonists? Okay, PPAR alphas and PPAR gammas is a completely different thing. Only thing you need to remember is the PPAR gammas or the glitazones in terms of diabetes management. PPAR alphas per se, saroglitazole we use only, if your patient has hypertriglyceridemia, triglyceride more than 500, there is data. There is approval for saroglitazole for you, saroglitazar in these patients to reduce triglycerides and for, like I said, NAFLD and MAFLD. SGLTs in type 1, I already answered. Voglibos and acarbos in type 1, these are all off-label actually. If your patient's postprandial glucose control, maybe a little Voglibos, acarbos, but honestly, we don't use any of them. As it is, they are on basal bolus. You are giving them prandial shots of insulin to control the postprandial peaks. So I don't think you need to burden them with pills simply because of this. All that they do is delay the carb absorption. Gastric emptying is delayed by them. So I don't think in type 1 diabetes, you don't really have that kind of a defect. In type 1, the defect is insulin secretion is lost. So it is not really going to, have much benefit. So my question is ignored, Krishna Prasad. Let me just go back to your question, doctor. Ma'am, my question, diabetic nephropathy versus DKD, I answered this. I explained diabetic nephropathy versus this, no? Diabetic kidney disease, diabetic nephropathy are essentially same. DKD and CKD I explained. I think we've addressed most of the questions. Is there anything else that we need to address? Or can we wind up? We far exceeded time. Yeah, I think so. I think we're done with it. So maybe we can log out now. Thank you so much. Good night. Take care, everyone. I hope this was useful. Thank you. Bye-bye.